Welcome to today's webinar hosted by VitaFlow titled Ketotic Glycogen Storage Diseases, Current Knowledge and Evidence Review. This is part one of a two-webinar series titled Ketotic Glycogen Storage Diseases, Faroe Islands and German Perspectives. I'll give more details on the other webinar at the end of this webinar. A few housekeeping items before we get started. The webinar will last approximately 60 minutes and will include time for questions at the end. If you would like to ask a question, please use the question feature on your GoToWebinar toolbar. All questions will be screened and a select number will be answered by the speaker at the end of the presentation. The webinar is being recorded and will be available on VIA in the next 2 to 3 weeks. You can access PDFs of the presentation slides, a certificate of attendance, and a self-reflection tool in the handout section of the toolbar. Please take the time to download these now, as they will not be available to download once the webinar has finished. To ask questions, please click on the orange arrow on the right-hand side of the screen. The toolbar will then pop out. Go to the question section, clicking on the white arrow on the left-hand side. This opens up the question panel so you can type a question. By clicking on the icon on the right, pops the question panel out into a larger, separate window. There now appears a disclaimer on the screen. In summary, the views herein are of the presenter and do not necessarily represent VitaFlow's views. The material herein is accurate as of the date presented and for educational purposes only. It is not intended as a substitute for medical advice. With all that said, VitaFlow is delighted to introduce our speaker for today's presentation, Dr. Ulrike Störewald. Dr. Ulrike Störewald is a pediatrician in Germany and Switzerland with a focus on neonatal intensive care, child neurology, and inborn errors of metabolism. In the 1990s, she spent 5 years in the Faroe Islands, gaining valuable insight into conditions such as GSD type 3A, SUCLA2 deficiency, and primary carnitine deficiency, and establishing professional links that continue to this day. In late 1998, Dr. Störewald relocated to Germany, but kept a strong relationship with the health system in the Faroe Islands. Currently, she works half-time in screening laboratory in Hanover, Germany, but also spends 3 to 4 months of the year in the Faroes, functioning as a consultant for inborn errors of metabolism and as a senior research associate of the Department of Public Health. Outside her work, Dr. Störewald enjoys being outdoors. She also rides her bicycle to her work in Hanover, which is 16 kilometers one way. Dr. Störewald plays the violin in a chamber orchestra and enjoys singing. VitaFlow would like to thank Dr. Störewald for taking the time to present for us today, and without further delay, I'd like to hand over to her.
Hello everyone. I also have a disclosure. There is nothing special to declare, just only that I got some travel compensations for my function as an independent clinician in the trial steering committee for the GLIDE study, and some lecture fees from different support groups. First, some of you might never have heard about the Faroe Islands. And you see, I'm walking in between the two of them, not walking, traveling. I'm usually living in Hanover in North Germany, the Faroe Islands, somewhere between the northern coast of Scotland and Iceland, is up in the northern Atlantic. But it is easy to come there, to go there, if you have done it for some time. And I'm there, I would say, something like 6 or 7 times a year, summing up to something like 3 or 4 months a year. Okay, what will we talk about today? First, we have to get the basics. That's how is glycogen built up and broken down again. Then I will go through some more details about the ketotic glycogen storage diseases. And then last, how to treat and monitor these ketotic GSDs. We really begin at the beginning, because to understand what we are talking about, you have to know where we get our energy from. Most important, that is carbohydrates, all different kinds of sugars. I'm quite sure you know some of them. I put some examples here. For example, bread and pasta and cornflakes, fruits. Don't forget about the vegetables and milk or dairy products. Important questions. What do we use these sugars for? That is mostly for the brain. Our brain loves sugars. The next big group of sources for energy, that's fats. And I'm quite sure you know where that is coming from. For example, butter or oil, and again, milk, quite a lot of other things. And what do we use the fats for? Fats give us a lot of energy, and that's what we use for exercise. Last group, protein. Where does protein come from? Cheese, all kinds of dairy products, meat, fish, very important in places like the Faroes, nuts. Now something you might not know about, beans. And again, milk. Why is protein so very important for especially this group of GSDs? That is because you first need the protein for growth, but also as a second line energy source. Very important. Carbohydrates that we eat are all broken down, usually into glucose. Partially that happens in the intestine, partially that happens in the liver. This glucose can be stored as glycogen in the liver, but also in the muscles and in other places. And you can see you have some straight lines between the glucose. That's what we call the 1,4 bound, because if you start to count the corners of the glucose, then you come from number 1, 2, 3, 4, and you have this 1,4 bound that gives you a straight line, a straight chain of sugar. But we have also these side chains. That's a 1,6 bound. That's how glycogen is built up. Lot of sugar put together to a long line with side chains. Look at this. That is glycogen. And also here you have the 1,4 bounds and some of the 1,6 bounds. And here you can see up to 30,000 glucose can be put together in one glycogen. That will say glycogen is a very nice way to store your sugar. And that, as I said before, usually happens in the liver and in the muscles. What do we use that glycogen for? When our blood sugar falls low between the meals, when all the food that we ate has been used, then glycogen can be broken down again into glucose. Be careful, it's only the liver that is able to set this glucose free into blood again. The muscle does not have the ability to set the glucose or send this glucose into the blood. No, the muscle will use the glucose itself. Now, I want to show you once again how blood sugar is kept stable by using glycogen, or what we call glucose homeostasis by using glycogen. All different kinds of carbohydrates are finally broken down into glucose. This glucose will go through one special substance that is called glucose 6-phosphate, not that interesting to know, and then put together to glycogen. And as I showed you in the last slide, when blood sugar is falling low, glycogen will go the same way back, or the sugar will go the same way back via glucose 6-phosphate to glucose, and blood sugar will go up again. Now, how does this look like in the ketotic GSDs? First, we'll take type 3, 6, and 9. The buildup of glycogen just works like it usually is, from carbohydrates to glucose via glucose 6-phosphate to glycogen. But then, if glycogen is supposed to be broken down, there's a stop. You see, the way down from glycogen back to glucose 6-phosphate doesn't work. And it is for all the three of them in this part between glycogen and glucose 6-phosphate. That's why I put them together in one slide. What is happening? You'll start to store glycogen, more and more glycogen. That's why your liver will grow, because most of this glycogen will be stored in the liver, and your blood sugar will continue to fall. We have gratefully a possibility to stabilize that. I'll come to that later. The other GSD, ketotic group of GSD, the type 0, that's a little bit different, because in type 0, the mistake in metabolism is here. These people are not able to build up glycogen. You see, they don't have glycogen or very little glycogen. That's why they are not able to break down glycogen to stabilize their sugar. But they will use the same mechanism to stabilize blood sugar as the other three types of GSD. What is happening in GSD 0 after a meal? You see, glucose is not able to go the way up to glycogen, so it will take this way via pyruvate to lactate. So these people will have a high lactate after a meal. And the blood sugar later on, when they have used all their sugar, will continue to fall low, because they don't have any possibility to break down glycogen. There is no glycogen. Now we want to have a look at what can these people with a ketotic GSD do to stabilize their blood sugars. Gratefully, the body has the possibility to create glucose from protein. So if your blood sugar is falling low, you'll start to take protein. Protein, mostly stored in your muscles, will go through something that's called pyruvate back to glucose 6-phosphate and then to glucose, and your blood sugar will go up again. A very small amount of the protein is transformed into something that's called acetyl-CoA, and there is quite a number of fat that will be transformed into acetyl-CoA. Little bit of the fat can go the same way as the protein. The body can't differentiate between the way to transform the protein into sugar and to use the fat from your fatty tissue. So at the moment when you start to break down protein, you'll start and mobilize fat from your fatty tissue. So this usually will happen together. Why is that important? Because this acetyl-CoA will be transformed in ketones. Ketones that are not that bad because your brain can use the ketones as kind of an alternative fuel. I usually use to compare the ketones for your brain with the situation. If you have a regular car, but you put the wrong fuel in it, it might work, but the car will not like it. It is very important to know about the ketones, because if you try to figure out whether a person that can't break down glycogen but can use this way that is called gluconeogenesis, whether they did have a low blood sugar, you might miss them because their blood sugar had come up again from this gluconeogenesis. So if you only look at the glucose, you will miss most of these cases. But if you check their ketones, that can be done by stripes. They look more or less similar like the stripes that you use to check your glucose. If you check the ketones, then you'll find out, whoops, high ketones, then you know, there was a period where your glucose was low. So now you understand the definition for the ketotic GSDs. All the GSDs are disorders that originate from mistakes in the buildup or breakdown of glycogen. That usually happens because there's some genetic mistake. But in the ketotic GSDs, the gluconeogenesis, the production of glucose from protein, is working. And this glucose can be set free into blood. As at the same time, fat will be transformed into ketones. You'll find these ketones in the blood. And that's what makes the definition of the ketotic GSDs a mistake in buildup or breakdown of glycogen, but the ability to get blood sugar up again from gluconeogenesis, and on the other side, production of ketones that you can show in blood. These are the ketotic GSDs, and you see in all four of them, GSD 0369, in the fasting state, you'll have elevated ketones, you'll have normal blood sugars or slightly low blood sugars, and you'll have normal lactate. That will help you to differentiate these ketotic GSDs from the other GSD, type 1. Type 0 has some special markers after a meal. These people have high blood sugars because they can't store the sugar, and they have elevated lactate after the meal. Now, you might want to know whether there's any clinical difference between these 4 different types. Yes, we'll go through them. The type that I know most about is type 3. I put down the gene, the AGL, the glycogen deep branching enzyme that is defect in these people. for type 3A, that is it's defect in liver and in the muscle. For the type 3B, the enzyme defect is limited to the liver cells. These people are able to break down the straight glycogen chains, but not the side chain. Symptoms in children. They store the sugar, especially in their liver. That will give them a very large liver, a big belly, and they store some of the sugar also as fat around their belly. You can see it in the face. You find low blood sugars. You find high fats. We have to talk about that perhaps in the next session. You'll find that these people have sometimes very weak muscles. Do you know why? Because they use the protein from the muscles, especially in type 3A, to keep their blood sugars up. The same will also cause them to have a very low endurance, very low stamina. If they have to walk for a long time, they are not able because there are no muscles. Most of them will develop cardiomyopathy because they store glycogen and fat in their heart. That's not too bad because with the right treatment, this cardiomyopathy will improve later. Most of the kids are late to reach their motor milestones because they have very weak muscles. And they won't grow like the other kids. Again, why? Because they use the protein that's supposed to get you growing. They have to use their protein to keep blood sugars up. And they have usually a completely normal mental development because their blood sugars don't tend to get too low. What I am scared of much more are the complications in adults. If they don't get the right treatment, they'll develop a bad myopathy. Most of them will end up in a wheelchair at the age of 35, 40 years. The liver usually will shrink, not because it is getting better, but because these people will develop cirrhosis that worsen because of ketosis and because of smoking. Sometimes they even might develop cancer. If they are not treated well, their cardiomyopathy won't improve. We have the clear feeling that these people have a higher risk to develop type 2 diabetes when they get older. They get very weak bones. I've written down all the different explanations why. And something we don't know very much about yet, but I'm quite sure that it is happening, that they get something that's called a neuropathy. They start to store glycogen in their nerves, and that will add to the problems in the muscles. Symptoms in type 6 and type 9 usually are less severe. Also, these people have a large liver. They have a poor growth. They are late to go to puberty because they don't have the energy, they don't have the protein. They tend to have low sugars in the morning with elevated ketones. They are at risk to develop hepatic adenomas or cirrhosis. And very rarely in type 6, we have seen cardiomyopathy. Type 9, that's a very common type. Again, the large liver, the poor growth, delayed puberty, high ketones in the morning. And these people, it looks like they have really an increased risk to develop liver fibrosis, cirrhosis, especially if they did have abnormal liver function tests as children. And something that seems to be very, very common in these people too, they get the ADHD, attention deficit and hyperactivity problems. That's all for those who are not treated. Here's a young man. The parents were so kind to allow me to use his pictures. He thought that it is not enough to have type 9A, but he is a carrier for the type 6 too. And you can see on the left side, that was when the parents first contacted me shortly before he got the diagnosis. You see the large belly. His liver went really quite down to far into the belly. You can see the thick cheeks. Something you also can see that a lot of people won't believe is that he has muscle hypertonia. He has very weak muscles. There's a little bit of fat, but not a lot of muscles. And look what he is doing with his leg and with his feet. And you can see it in his face too. Then we talked together. I told the people, the parents, what to do. And only 3 months later, you can see the young guy. Okay, he gained some weight, but you look at his legs. And 5 months later, or after 5 months of treatment, that is already a different child. Look at the belly. Look how he's standing now. And that's only after 1.5 years in treatment. You should see him now. He swam and got a test because he was swimming so well, and you only can see his muscles, no more liver, no more enlargement of the liver, so he's doing totally fine. And I think every one of you will agree that his muscle tension is completely different than it was in the first picture. Type 0, they have some special signs. Their blood sugar gets up after the meals, so it is worth not only to check blood sugars before a meal, but too something like 1 hour after a meal. Their lactate is getting up after a meal. So this combination should get you suspicious, should get you to think about type 0. These people also have low blood sugars with high ketones, especially in the morning. They very often are very tired. I know several of them who even got seizures in the morning. Now you might ask, why do they have a large liver if they don't store glycogen? That's because they store fat. Do you remember? If the blood sugar is going down, they mobilize the fat from the skin. And if you don't need all the fat, and not all fat is transformed into ketones, the remains will be stored as fat in the liver. So they get a non-alcoholic fatty liver disease, all of them, and they also have a poor growth. What can you do to help these people? You have to find the balance between providing enough energy for these people that they can function normal life without causing overstorage of glucose or sugars as glycogen. That's not easy, but it can be made. Just enough of cornstarch, carbohydrate, to avoid hypoglycemia, so these people don't have to break down their protein. And on the other side, give them enough of protein to refill their muscles, and in case that their blood sugar was low, that they can use this protein to stabilize the blood sugar, especially for type 3. You have to adjust the dose, and we usually do it by prescribing these people a glucometer so they can check their glucose and their blood ketones at home, and also, especially in those with muscle problems that will say the type 3, that they can have a look at their muscles. What are the principles for the diet in these people? It's the same for all 4 types of GSD. The first, very easy, frequent small meals, so that the interval between the meals doesn't get too long. Use carbohydrates that are slowly absorbed from the intestine. That will help you to keep your blood sugar stable without being dependent from sugar, from glycogen in the liver. Don't use too much carbohydrates, because then you'll cause overstorage. You see very strict numbers that you really have to follow, especially the numbers about the simple sugars. We'll talk about that in the next webinar. High fiber food. Try to combine your carbs with fiber, protein, and fat. This will further delay the absorption of the carbohydrates and will help you to keep your blood sugar stable. Uncooked cornstarch. Cornstarch looks very similar to glycogen. So now you might ask, how should cornstarch help if these people can't break down glycogen? They can't break down glycogen in their muscles or in their liver, but in the intestine, you have enzymes, you have substances that can break down the cornstarch, and that gives you a very small amount of sugar per minute or per hour that helps you quite a lot to keep blood sugar stable, whether it is the cornstarch or whether it's glyphosate that will be even more slowly broken down than cornstarch. So most of the people have to use cornstarch, especially during the night. A bedtime snack, so you start the night with a stable blood sugar. High protein, just to refill your muscle storages if you had to use some of it for stabilizing blood sugar, and to have some extra protein in steak if your blood sugar is going down. Some supplements, and we highly recommend some probiotics, because those who have to use cornstarch usually tend to get some extra air in the belly or tend to have higher risk for developing gastroenteritis, infection of the intestine, because the cornstarch will change the composition of the bacteria in your intestine. So probiotics helps quite a lot. What do we want to come to? We want to keep blood sugar stable in a very, very narrow range. I know that is really very hard to reach or to keep blood sugar in these limits. It is possible, and the better you do, the better you will feel. Try to keep ketones low. We usually say not more than 0.2, especially in children. Adults might tolerate somewhat higher ketones without any problems. We want to reach normal growth. That is possible. We want to have a normal strength and endurance in these people. That's hard for type 3A, but all the other ones should easily be able to reach that goal. And what I think is very important, these people should be able to lead a normal life, to have a good quality of life. We do not only want to have normal numbers in lab, but I think it is also very important for them to have a good life. Alternative dietary managements beside the protein and the cornstarch. Ketogenic diet, some of you might have heard about it. High-fat diet. I know there have been some trials to use this diet. Some of the people might profit from the high-fat diet, but it is still a problem because we don't know about the long-term effects, especially of the ketogenic diet. I don't have any experience with this, and up to now, I did not find it necessary to ask somebody with one of the ketotic GSDs to use, for example, ketogenic diet or high-fat diet. Some trials used MCT oil to try whether this extra energy could help for exercise. But my experience is that this works too late. And very recently, we tried a ketone drink, hoping these ketones could help your muscles to perform better. But we have shown that this only helps in people who really have a myopathy, those who have been exercising and who are well, who have a very good muscle function. They usually don't profit from this ketone drink. So I don't know. There are some options, but I don't have enough experience with this. I tried to collect the possible risks of a high-fat or ketogenic diet. If you use a lot of fat, you might store the fat in the liver, and a liver that has been irritated by the only partially broken down glycogen is very, very vulnerable for any other irritation. So some people found that you might have an increased risk to develop carcinoma. It looks like those who use the high-fat or ketogenic diet, that they don't grow as they were supposed to grow. And also some problems from the bones have been shown. So you really have to watch out if you use one of these diets. Something I like very much, that is exercise. I found in my patients that those who exercise on a regular basis are doing extremely well. I think everybody knows that exercising is something very good. But in people with GSD, exercise is even better. If you exercise on a regular basis, you teach your muscles to use fat. So you have more sugar left for your brain. Your blood sugar is more stable than if you don't exercise. You won't gain too much weight and thus have a lower risk to develop type 2 diabetes. So that seems to work very well. What do we have to do for the treatment in ketotic GSDs? First, it is not enough to check blood sugars, ketones once or twice a year when you see your physician. You should be able to do that at home. You have to decide together with your physician whether it is enough to do the home monitoring by using sticks or whether you need continuous glucose monitoring. Very important, you have to be able to check your ketones. Do you remember from the first slides? Sometimes you won't realize that your blood sugar has been down if you won't see high ketones. We usually control growth, BMI, so we can be sure that we don't overtreat. You have to have a look on the liver. We check the heart, especially in type 3A. We check bone density in all those who finished puberty, and we do a lot of lab controls. Why do I ask people to control their ketones? Elevated ketones tell me that your metabolic control is not as good as it should be. If your ketones are getting very high, you will get into problems because then gluconeogenesis will stop. With very high ketones, I would guess with levels of 2.0, 2.5, your body won't be able to transform protein into sugar, and then your blood sugars will go down. High ketones during surgery are really dangerous because then you will get too much acid in your bloods. The ketones are acids that will give your body a lot of problems. So don't fast before surgery or anesthesia. You won't tolerate it. Here's the list of the labs that we ask people to take. You see, it is a very long list with a lot of different things. We have to go through this the next webinar. What can you do to improve your liver numbers? That's actually very easy. Your liver numbers will be up if you store too much glycogen or if you store too much fat. That will say you'll get better liver numbers if you avoid too much carbohydrates or too low blood sugars, because then you'll start to store fat in your liver, and a very bad substance for your liver, that's alcohol. Muscle numbers get up if you always are using the protein from your muscles. How can you avoid that? Again, very easy. Keep your blood sugar stable. You can help your body by eating extra protein, and don't overdo exercise when you're starting to exercise. What about the protein numbers? They will be low if your body had to use the protein because blood sugars were low. So again, be careful, try to keep your blood sugars fine. Cholesterol, oh, we didn't talk about that yet, but cholesterol is something that will come if the body starts to break down the fat. When does the body in a person with ketotic GSD has to break down fat? As soon as blood sugar gets low. That will say you can normalize your cholesterol numbers by avoiding low blood sugars. How can you improve your glucose numbers? Very easy. Follow the diet, not too much, not too little carbohydrates. Very important, in adults, we very often see overtreatment that will lead to type 2 diabetes. One further option for treatment, that's gene therapy. We are just at the beginning of this. The first of the GSD types can now be treated with gene therapy. So in the future that might become available for the other types too. So now we are already at the end. And I can tell you, those who really try to get a good metabolic control will have normal labs. I have several adult persons. If you look at their labs, you won't believe that they have GSD and they have a very good life. And I only can recommend that everyone tries to get the best labs that he can achieve, because we don't know everything about the late complications in GSD. So it is best really to try to have your metabolic control as good as possible. Here is some reading if you need more background for the whole thing. And in the end, I have to thank to those who teach me all what I know about GSD in the front line, and that is David Weinstein, now at Passage Bio in Philadelphia, and Terry Dirks from Groningen, the dietitian of David Weinstein's group, Kathy Ross, and the whole team of the Glycogen Storage Disease Program over in Hartford and Connecticut. Not to forget to say thank you to all the patients and their families who share their experience with me, the practical advices. I am really very grateful to them. And thank you for listening, because that will help your patients, you, your families, yourself to get a better life. Thank you.
Thank you, Dr. Störoval, for taking us through this topic in so much detail. We have a few questions that have been submitted. First question is there any difference in outcome regarding cardiomyopathy and proximal muscle weakness with GSD type 3A compared to GSD type 3B?
Sure. Type 3B, in these patients, the muscles are not affected. So usually you might find some muscle problems because they too have to use some of their protein to keep blood sugar up. But it is usually not as bad as it is in type 3A. It's usually type 3A who get the myopathy and the cardiomyopathy.
Thank you. The next one is just a clarification, really. Is GSD type 11, Fanconi-Bickel syndrome, a ketotic form of GSD?
Yes and no. I usually would put it in the line with these GSDs. They don't produce too much of the ketones, but their treatment follows more or less the treatment of the ketotic GSDs.
Okay, thank you. The next one is about probiotics. What sort of strain would you use and what dosages?
Oof, that's a good and a very hard question, because probiotics that you will get in your country will differ from the probiotics that I, for example, recommend up in the Faroes. Usually, if you try to find something with lactobacillus in it, that will help. It is just by using cornstarch, you help some of the bacteria in your intestine to grow, to multiply, and that will lead to a disbalance of these bacteria. So to help keeping the balance where we want to have it, we use these probiotics. Just try to find a preparation with lactobacillus in it, and you just have to ask your dietitian which one is used in your country.
Thank you. Now, there are a few questions around the dosage and the usage of uncooked cornstarch. Would you be able to discuss your recommendations for the uncooked cornstarch dosing, please?
Yeah, again, a hard question. During night time, I usually would start with something like 1 gram per kilo, and then you have to figure out how long this cornstarch will last. It depends on the age of the child. It depends on the residual activity of the enzyme. Very often, the genetic defects leave you with some activity of the enzyme. So some children or some persons might need some more cornstarch, some might need less cornstarch. Usually it helps quite a lot if you add some of the protein, especially for the type 3A, but also for the other ones, especially again during night time, because it is during the night that we grow, and that helps you to prolong the effect of cornstarch. But you have to check whether it lasts for 4 hours or for 6 hours. In older kids or in adults, one dose might be enough for all the night. But you really have to check. You have to figure out how long. All those patients are different. So you just can't say everybody has to use the same number. It's the same during daytime. You have to find out how long these people can run on their last dose. That depends on activity, that depends on the weather. If it is very hot or very cold, you need more. And again, it depends on your residual activity of the enzyme.
Thank you. Now, over to protein. Now, how do you decide? What additional protein would you give to particularly type 3A patients? Obviously, the recommendations is quite high. So, what would you recommend as an additional source?
That's again depending on the place where you are living. You have to. We usually say the protein powder that is made from away from milk, because the amino acids, the composition of the protein, that's the one that we best can use in our body. All kind of protein powders you use, you have to check very well before you start using them. I know there are some preparations that athletes, that sportmen are using, but very often they contain small amounts of anabolics, of substances that will help your muscles to grow. But on the other side, if you have any issues with the liver, and all these ketotic GSD people, they have a liver GSDs. These people are at a very high risk to develop problems, adenomata, or even cancer in the liver if they take these protein powders that you can get over the counter that are not 100% free of steroids or anabolics. So be very careful. Again, ask your dietitian which of the protein powders, and it should be a mixture, not just 1 or 2 amino acids, which one is best.
Okay, thank you. Thank you. I have a final question here, just conscious about time. So the final question is, given all the side effects of the ketogenic diet, do you see any benefit to continue to pursue this avenue of treatment? Would there be any benefit above and beyond the current standard treatments?
For the ketogenic diet, I think there might be some adults or some people with severe myopathy that might profit from a modified Atkins diet. I see it the way that most of the people, or the biggest difference between the regular GST diet and the ketogenic diet is to reduce the carbohydrates. And from my experience, one of the biggest problems is overtreatment. Most of the people get too much carbohydrates. If you start with a ketogenic or a modified ketogenic diet, you are reducing the carbohydrates. And if you then substitute enough of protein to your diet, then you'll see a lot of improvement. On the long term, I'm not sure whether that helps. I just recently was contacted by a patient who is 39 years now, and he has been on ketogenic diet for something like 8 years. He developed a stroke and brain hemorrhage later on, possibly because of the ketogenic diet. So there are side effects, and this man still has a very severe myopathy. So especially if your numbers don't improve, I would be very careful to continue with this diet if it is not extremely well controlled, and if you make sure that you get the protein you have to use. For me, one of the major problems with ketogenic diet is that I can't use the ketones to figure out whether the metabolic control is at the level that I want to have it.
Thank you. Thank you very much. So thank you all for joining us today and for sending in your questions. Once again, I would like to thank Dr. Ulrike Størevald for taking us through the Ketotic GSDs, Faroe Islands and German Perspectives Part 1, Current Knowledge and Evidence Base. For everyone listening, we hope today's webinar has been informative and helped advance your knowledge in this area. Before we conclude, I'd like to remind you of the second part of this webinar series, Ask the Expert Your Questions on Ketotic GSDs Answered. The second part will take place on June 9th at 3 p.m. BST and is a great opportunity to gain practical management knowledge in this area. Full details and registration link can be found on VIA. Please submit your questions for this session to VitaFlow webinar at vitaflow.co.uk by Friday, April the 30th. This concludes today's webinar. On behalf of VitaFlow, I, Tina Heinonen-Kirk, would like to thank you for tuning in today. Please take the time to complete the evaluation questions before leaving the session. The certificate of attendance is available to download from the handout section of GoToWebinar toolbar. Goodbye from me and enjoy the rest of your day.